of erectile dysfunction.
Respected Chair and dear delegates, myself Dr. Mohsin. I'm Assistant Professor in Urology in Guntur Medical College. So the topic given to me was newer therapies for management of erectile dysfunction. This is actually an evolving topic and it is in still research in many parts of the Western countries. And I brought some data from Western countries to present my talk, as well as I start my talk with mentioning about avanafil, which is a new drug, and from there what is the need for newer therapies, and at the end with the help of a guidelines I'll present in front of you. So no conflicts of interest. Avanafil, it's a benzylamine pyrimidine derivative, as you see the molecular structure there. FDA approval is got in 2012 and it's commercially available in 2013 in European Union. In India, it's launched in 2021. It is, we all know it is a highly selective PDE5 inhibitor. 50 mg, 100 mg and 200 mg are commercially available doses for on-demand therapy. High ratio of inhibiting PDE5 as compared with other PDE5 subtypes, ideally allowing the drug to be used in ED while having minimal side effects. As we all aware of this mechanism of action, so initially nitric oxide release should be from the nerve endings, so initial sexual stimulation is necessary. So when the cyclic GMP, this PDE5 inhibits degradation of cyclic GMP, hence there is accumulation of cyclic GMP, and that leads to relaxation of the vascular smooth muscle and vasodilatation, as a result increase in blood flow. There means a mechanism of erection. And this can be taken in 15 to 30 minutes prior to sexual activity. It's a very fast onset of action compared with the other PDE5 inhibitors. It absorbs quickly, reaching a maximum serum concentration in 30 to 35 minutes. It has a minimal effect with food. It can be taken with or without food, no problem. And the dose adjustments, it doesn't depends on the impaired renal function or impaired hepatic functions. It can be. And the side effect profile is minimal compared to other PDE5 inhibitors, but still a few of the side effects noted, which are minimal. So the mean percent of attempts results in successful intercourse was approximately 47%, 58%, 59% in this following 50 mg, 100 mg and 200 mg dosages, which is compared with placebo, which is 28%. And similarly, within 15 minutes of taking a tablet, the successful attempt is 64%, 67%, 71% of cases with 50 mg, 100 mg, 200 mg respectively. So a recent meta-analysis confirmed that avanafil has comparable efficacy with sildenafil, vardenafil and tadalafil. So what is the need for neotherapies now? It's erectile dysfunction, which is refractory to medication, non-compliance, patient non-compliance, potential side effects and contraindications of these drugs in few patient groups, and not satisfied with other modalities. Not ready to accept for surgery. These are all we are thinking in new terms of restorative surgeries or regenerative surgeries. So restorative therapies for erectile dysfunction are a newer frontier of treatment focused on regenerating diseased tissue and providing a potential cure for erectile dysfunction. These are the regenerative therapies. One is shockwave, another is stem cell therapy, and platelet-rich plasma. These three are in emerging phase. Coming to shockwave therapy, as we all know, we use in ESWL shockwave therapy that is a focal shockwave on the target on the kidney stone. Similarly here, the shockwave is a radial shockwave, so it exposes the larger focal volume with the larger area of the spread. And these are the few devices which are available globally for this purpose. Coming to the basics, shockwave, a disturbance that propagates through any medium at a speed of faster than the speed of sound travels through a medium. There is a rapid rise in pressure in the short interval of time, as you see in the curve, and the energy is measured. Energy density is energy flux density is the amount of energy that is delivered to the specific area of the tissue. So here, what we use is radial shock waves, which is nothing but a Gaines wave technology. Here, the radial shock waves are nothing but having a very, very low pressure, 100 times lower pressure than the usual shock wave. With pulse duration is also longer; it's 1,000 times longer than usual. And the energy flux density and depth of penetration is superficial. Hence, we use in this purpose. Therefore, it is a medical class 1 device and it's safer, no harm to the patient. As I said in my previous slide, I compare with other energy modalities where you can see the radial pressure, which is a very low pressure, and as time takes to, it's slow, very slow to time takes to, and the focal volume is also, it's not focused on area, it's a radial energy, and the total energy is very low, and penetration depth is very shallow, that is less than 1 centimeters. Hence we use this. That's why it's classed under class 1. Now the mechanism, after subjecting the corpus cavernosum to shock wave, so these things happen in the molecular things happen, it activates the nerve repair that releases a lot of nitric oxide and active resident stem cells, and they recruit stem cells, they recruit immune cells, initiate that helps in wound healing, and it restores a normal endothelial signaling because of all vascular endothelial growth factors that leads to a neoangiogenesis. And there is this is a meta-analysis of 7 RCTs conducted by Ramsamy team. Here the ED scores were subjected, and 602 subjects were taken with the age group of 60 years with follow-up of 5 months. They noticed IAF score was improved like 6.4 compared to the 1.6 in sham group. And similarly, another meta-analysis of 7 randomized control trials with 833 subjects was with follow-up duration of 3 to 6 months. There is improvement in score, IIEF score, and there is therapeutic efficacy of at least 3 months. And patient with mild, moderate ED has a better therapeutic efficacy. So this is a phase 2 RCT with 2 schedules. In this RCT, 80 men were recruited of 30 to 80 years age group, and the baseline score was 11 to 25. This patient group was randomized into 2 groups, a group A and group B. So, and the IIEF score and EHS, erection hardness score, these 2 scores are measured baseline and 1, 3 and 6 months. And this is how the results were. The IEF score, so in group A, 720 shocks were subjected on a daily basis for consecutive 5 days. And group B, 600 shocks were subjected every alternate day. That is for 6 days, I mean it's like for 2 weeks. In group A, there is a fluctuation in results where IAF score was initially improved, followed by a dip and again improvement. In a group B, there is a gradual improvement, but over group A, group B, group A, who were subjected daily for 5 days, shows a bit improved efficacy compared to group B in IIEF scores. Compared to erection hardness scores, in this course there is a gradual improvement of group A efficacious. So now whether this is a question mark whether we can inculcate the shockwave therapy in our routine protocol, like along with lifestyle modifications or along with PDE5 inhibitors in this algorithm. What AU says, AU guidelines of low intensity shockwave for men with ED, low intensity extracorporeal shockwave therapy should be considered investigational, that is level C. And given the availability of other treatments that are less burdensome and known to be effective, and fact that ESWT is not FDA approved, the panel concludes that ESWT should only be used in investigational settings in the context of an institutional review board approved by clinical trial. Now coming to stem cell therapy, stem cells, as we are all aware, stem cells are, we get bone marrow, adipose tissue, umbilical cord, self-renewal and potential to proliferate extensively and ability to develop into multiple lineages. So this is how aspirated from the bone marrow, and these stem cells are 3 categories based on heterogeneous culture. Finally, the aspirate, which is that will be injected into the corpus cavernosum. Similarly, stromal vascular fraction through a liposuction procedure. The stromal vascular fraction that is settled at bottom, that is collected and injected into corpus cavernosum. The idea of stem cells is how they help by 2 theories are there. That one is building block theory, which says the direct replacement of the corpus spongiosum, and the another one is paracrine theory, which tells about the mesenchymal cell that supports by the releasing cytokines. And this is a study conducted by Ramsamy team et al. In various parts of US, where there are mixed results with high cost involved in these things. And most of the things most of the centers use adipose tissue, and some of the centers use all 3, bone marrow, adipose tissue. This is another study. So in this study, the transendocardial stem cells were injected into in the patients of cardiomyopathy. So this study concludes that erectile function doesn't appear to improve with stem cells given systematically. AUA guidelines for men with ED, intracavernosal stem cell therapy should be considered investigational again. So findings from studies that have evaluated stem cell therapy does not indicate the benefit reliably outweigh the risk burdens of men with ED. In particular, the treatment ability to restore normal erectile function in various populations of men with ED has not been convincingly demonstrated. Further, neither the most effective source and dose of the stem cells nor the duration of the treatment effect has been established, and burdens associated with obtaining the treatment. Cost need for the tissue harvest can be substantial. Given the paucity of the data obtained in the human participants, the risk of treatment also not well established. Now, platelet plasma, as we all aware, the orthopedicians are using it recently. So plasma, there are poor plasma and rich plasma is there. We are using rich plasma for this, for our purpose. So blood is collected, and the platelet-rich plasma, which is in between, above the plasma is discarded, and the PRP is used for injection into corpus cavernosum. So this is study indicates 4 men with ED and 1 with ED and Peyronie's disease. So between 4 and 9 ml of PRP was injected in corpus cavernosa per treatment session. A mean of 2.1 injection procedures per patient was performed, and IAF score improvement was seen with minimal adverse effects of mild pain in 23% and bruising in 6% of the population. This is a Miami trial of PRP in erectile dysfunction. So here the 72 men were included in the study, 30 to 75 years age group. So IAF between 11 to 25. So primary outcomes were improvement in IAF. So AAU guidelines for men with ED, platelet-rich plasma therapy should be considered experimental. The SMSNA statement thus given in the current lack of regulatory agency approval of any restorative therapies. SMSNA believes that use of shock waves or stem cells or platelet-rich plasma is experimental and should be conducted under research protocols, and that should be fully informed and consented by the patients, that should be informed about risks and benefits of these therapies.
Can you conclude?
Yes, sir. So this is my this is guidelines from EAU guidelines. These are all recommendations about shockwave lithotripsy and PRP. Everything were weak recommendations as per EAU as well as of now. And to conclude, current ED therapies do not provide a cure for ED. The mechanism of how PRP, stem cells, and low-intensity shock wave improve erectile dysfunction appear to promising, and some initial studies have demonstrated benefit. At this time, the use of low-intensity shock wave, stem cell, PRP should be considered experimental until appropriate RCTs have demonstrated proven efficacy and safety. Thank you. Thank you, one and all. Thank you for giving me this opportunity.
We'll move on to the next question.
Yeah, thank you.
Hi, Mohsin. One question. How do you choose a young patient? Lot of young patients come with ED. How do you choose your PD inhibitor? What do you give?
So I go on with tadalafil 5 mg, sir. I go on with tadalafil 5 mg standard.
For all?
Almost all.
Then avanafil, where do you give?
So avanafil is a special thing where I use is refractory, usually refractory to tadalafil. I use avanafil. As of now, I'm using like that.
Thank you.
Thank you, sir.
Thank you.